I request you all to keep your microphones on mute. And before we begin, I would like to share a 2 minute video with all of you.
Enable my screen sharing. Prashant, enable my screen sharing. I'm not able to screen share.
Prashant, would you enable Mr. Deepak's screen share?
Okay, I think Shraddha, let's move on.
Sure.
Video now, let's move on.
You're the co-host now. You can actually do it now.
You already shared, sir.
Okay.
Sure. Can I move? Okay. Yeah. Yes. So, good evening to all once again. Good evening to our esteemed guests from across the world. I welcome you all to the webinar by Merrill Endosurgery. Our esteemed Deepak, would you just mute? Thank you. Our esteemed moderator today, Dr. Vivek Bindal, is the Vice Chairman of Institute of Minimal Access Metabolic and Bariatric Surgery at Sir Gangaram Hospital, New Delhi. He is a Regent, Clinical Robotic Surgery Association of India. Dr. Vivek has keen interest in robotic pediatric weight loss surgery. Dr. Bindal has an advanced fellowship in robotic gastrointestinal and bariatric surgery from the University of Illinois at Chicago, USA. He has worked as a faculty member in Division of Metabolic and Weight Loss Surgery, Duke University Medical Center, USA. He has also been trained in robotics and advanced laparoscopic surgery at the Center of Excellence around the world, which includes France, Italy, Florida, USA. He has one of the largest experiences in robotic and pediatric surgeries in Southeast Asia. He has published many research papers and books, chapters in this field in the reputed journals. He is actively involved in research in bariatric surgery. I would like to request the participants to please type the questions in the chat box so that the moderator can ask them during the question and answer session. And you also can raise your hand by clicking on the More tab. I would like to now invite Dr. Vivek Bindal and hand it over to him. Dr. Vivek, over to you, sir.
Yeah, thank you, Shraddha, and thank you, Merrill, for this opportunity. I think this is This is a uh, very pertinent webinar which has been organized by Merrill, and we can see more than 218 people are already in there, and we have esteemed speakers today. So the first uh, speaker is Dr. Heather Bugard, and she is going to basically speak on long-term outcomes of sleeve gastrectomy, Roux-en-Y gastric bypass, and one anastomosis gastric bypass. Dr. Heather Bugard is head clinical unit of surgery, New Somerset Hospital in South Africa, and she's a senior metabolic, bariatric, and laparoscopic surgeon. She is passionate about minimal access surgery. She serves as vice chair of Somerset Hospital Facilities Board, and she's also heading the COVID Management Committee of New Somerset Hospital. I think that's kind of the in thing now. So COVID is something everyone wants to learn more than bariatric. But anyways, the topic for her today is more about long-term outcomes of bariatric. So I would request her to please come forward, and then we'll have Dr. Narvaria from our own country. Nobody, there is no surgeon who doesn't know him. So then we'll have his talk afterwards. Dr. Bogart, all over to you, please.
Thank you so much. Thank you for the invitation. It's really wonderful to be amongst friends from India with the colleagues from Merrill, and really looking forward to afternoon together to discuss some of the interesting things that are going on whilst we have normal practice. It hasn't been normal for a while in Cape Town. We are 3 months since I last did a metabolic procedure. And so I'm not sure if that's supposed to be in my disclosures, but we are currently in elective surgery is completely out the window at the present time. But this is my hospital, and this is the view from my hospital. And Cape Town is normally a very beautiful place. It's still really beautiful, but there aren't any tourists at the moment. So it's important for you to have a look at this case mix disclosure, mainly because you'll see by the end of my presentation that although I'm speaking a lot about one anastomosis gastric bypass, I actually don't currently perform this procedure in my hospital. But I think just by way of introduction, and I think my Indian friends really know this very well, is that metabolic problems are really not just a first world problem, and it's increasingly a demand for us in the third world, because half of the obese patients that we find globally are actually found in only 10 countries. And I live in the country which is right in the middle at the bottom of your screen, which is South Africa. 8 of the 10 countries that are mentioned are in fact low middle income countries. And so I think it's just important to contextualize it. So we really need to have a good solution. And I think the question for many surgeons now, especially those embarking on metabolic surgery for the first time, is whether or not we have got ourselves into a position where we're spoiled for choice. We have so many options. How do we decide what to choose? And I think there are some general principles which we'll be able to run through today, and we'll try to get a handle on what we really know about these different procedures and what types of benefits they can bring to each clinical situation. And we're really trying to balance our decision making in terms of the type of procedure that we're going to choose and the risk of complications. And for those of us that practice in low middle income countries, it's really important for us to understand the costs for this, not only at the time of surgery, but also the long-term downstream costs. So if you think that it's going to be simple to make a decision about different procedures and about case selection, it's not going to be a straightforward situation. This is a little bit of a picture. It's the kind of thing that endocrinologists love to show us just to make sure that we are certain that we didn't understand them. But I think if we start off with the idea or with acknowledging that every single procedure has a vehement protagonist or maybe multiple vehement protagonists, then I think we'll understand that it's actually quite complicated and there isn't really a one-size-fits-all solution. Many of you will have been used to seeing these tables, but they've actually gone a little bit out of date because we're moving on. And I think for me, certainly the sands are shifting in terms of operative solutions or in terms of choices. So Roux-en-Y gastric bypass has been a long time been considered to be the gold standard. But there's been a trend over the last 10 years for laparoscopic sleeve gastrectomy to be increasing in popularity, but it has a couple of quite nasty complications, although they're uncommon. And so more recently, the one anastomosis gastric bypass or the mini gastric bypass or omega loop gastric bypass, as you prefer, has become increasingly an operation or a procedure to consider. It has really quite excellent results and a low complication rate. So I'm just going to mention very briefly these three different operations for those of you who aren't sure what I'm talking about or what I'm referring to. I'm certain most of you are well aware. Nevertheless, so sleeve gastrectomy that I'm referring to, well, all these procedures, we would perform them laparoscopically. I know in the hands of my esteemed colleagues, they may be performed robotically, but however you do it, it should be with a minimal access solution. So sleeve gastrectomy, just a simple restrictive procedure, and leaving a thin pouch along a sized bougie. The gastric bypass, which consists of creating a small diamond shape pouch and then a Y-shaped reconfiguration with a shortened common channel. And then the one anastomosis gastric bypass, which for me is quite reminiscent of a Bullroth 2 reconstruction, also with a small pouch, but this one much longer and thinner, and then a simple omega loop. So that's what we're referring to today. So let's take a look at the Roux-en-Y gastric bypass, and the reason why I'm starting with it is because this is something for which we've been practicing for many years. We have decades of information about it, and for some people this is still considered the gold standard. But the gastric bypass is technically a little bit more demanding of a procedure, certainly than the sleeve gastrectomy. It has a much longer learning curve. Although most of the groups report significantly better weight loss and less recidivism and more dramatic metabolic benefits. If you have a look there at the excess weight loss, or if you have a look at BMI changes, you can see really excellent results from this procedure. Then we've got the sleeve gastrectomy, which is popular because it's technically much less challenging. The learning curve is way shorter and the operative time is certainly shorter. It has acceptable weight loss and it has largely comparable comorbidity resolution despite the fact that it's significantly simpler. But it is hampered a little bit by the problems related to reflux and a 2% incidence of gastroesophageal junction leaks. It depends on the reports that you read whether or not weight loss is sustained, but there are reports as poor as only 50%, and then there are reports as good as 70-80%, so quite a wide range of results. And then the one anastomosis surgery has become the third most frequently performed procedure. And there is now pretty extensive level 1 data on this operation, and we'll run through some of that shortly. It's quite a safe technique. It has a fairly low morbidity and mortality risk, and it has a dramatic metabolic benefit and much less recidivism actually than either of the other two procedures, as you can see there. Some authors even suggest that the results are quite closely approximating much more complicated procedures like, for example, biliary pancreatic diversion. I think if you've been doing metabolic surgery for a while, you'll have seen this slide over and over. I think we're moving a little bit into the different domain now because we're not discussing that so much. So what we're going to be talking about is actually comparing the three that I've mentioned to you. Most of the information that I'm going to show you, or most of the graphs, most of the data is coming from this randomized controlled trial published in Surgical Endoscopy in 2019. And if there are some other references, I will show those to you at the time. But here are some further references just for your edification, and if you would like to take a check through for yourself. So we're going to start off with the things that we think matter, which is the results in terms of body mass index trends. And you can see here from this graph, just looking at 1 year, 2 year, and 5 year outcome. Hopefully all the graphs will be of in a similar configuration to make it understandable for you. But you can see there that the trends are fairly similar, especially at 1 year. And as we know, the patients tend to lose all of the expected weight within 1 to 2 years. But if you take a look at sleeve gastrectomy and Roux-en-Y gastric bypass, both of these procedures carry a risk or a complication or a perhaps expected result, depending how you view it, of recidivism, which may be as much as 25% in sleeve gastrectomy cases and approximately 10% in bypass cases. But if you have a look at that red line, which is quite plateaued, that's the single anastomosis procedure, and quite robust at this long-term stage that we're talking about. If we look at excess body mass index loss, I think the buzz phrase, if I could say, right now is that there's really no, or there's non-superiority of the Roux-en-Y gastric bypass. So this assertion that we have, or perhaps surgeons like myself who've been practicing for a while think that Roux-en-Y gastric bypass is still the gold standard. The data doesn't quite support that that bias. What the data also shows is that the mini gastric bypass is pretty dramatically superior in terms of excess body mass loss. So I want to spend a little bit of time just to look at the table. I try to make it simple for you because I know it's really difficult. I can't point on my screen whilst we're screen sharing. So I tried to make everything that I want you to look at in red. In the different colors on the left of your screen, you'll see the different operations and you will see the results. And we're specifically looking now at comorbidity resolution, type 2 diabetes, hypertension, and dyslipidemia. And you can look at those for yourself in detail. But the bottom line, if we take a look at type 2 diabetes and we want to look at the things that are statistically significant, there is really no difference between sleeve gastrectomy and Roux-en-Y gastric bypass, which is what I've already told you in the previous slide. But there is a significant difference between sleeve gastrectomy and one anastomosis gastric bypass in terms of diabetes resolution, but probably no difference between the single anastomosis and the Roux-en-Y. So these things are important because they're going to help us to make decisions about which patients to offer which procedures to. Then if we take a look at hypertension, once again, we really aren't seeing a significant difference between the sleeve and the bypass. But if you look at the 5-year results for hypertension, you'll see that there's a significant difference in terms of hypertension resolution for patients who have undergone one anastomosis bypass. And then probably the most compelling information, or for me, certainly one of the most interesting, is the resolution of dyslipidemia. And first of all, I think it's important to notice that actually the worst performer, if you like, is the sleeve gastrectomy, because there really isn't a benefit in terms of the LDL levels in patients who have sleeve gastrectomy. And so the reason for significant improvement in dyslipidemia in both gastric bypass and one anastomosis surgery is because of this mainly dramatic benefit in terms of LDL levels. So that's also something worth bearing in mind. So those are the important ones. We can have a look here. This is the actual graphs of the hypertension resolution. Just for those of you who like to see trends and who like to see things in image form, you can see there's a significant benefit in terms of hypertension resolution for mini gastric bypass. It's pretty successful results for gastric bypass. And of course, we're not making less of sleeve gastrectomy. It still performs really well. You're going to have a patient with a dramatic improvement, at least more than 50% of remission, which is not a poor result by any means. The type 2 diabetes, which is for me a really interesting one, you can see actually that there's very little difference between the Roux-en-Y gastric bypass and the sleeve gastrectomy. But when it comes to the mini gastric bypass, there is a sustained benefit, perhaps even a trend towards improving benefit as the time goes on. And it's quite interesting for me that this data is so dramatic, given that gastric bypass is still the recommended procedure for patients who have got type 2 diabetes. So just bear that in mind. This is the dyslipidemia trends, and it's exactly what I already mentioned to you, which is that there's a really dramatic resolution rate with the one anastomosis procedure. And both bypass and one anastomosis significantly outperforming a sleeve gastrectomy. I do want to just say that with patients who undergo sleeve gastrectomy, there's still a significant mortality benefit for these patients. And the main reason for that mortality benefit is because there's a reduction in cardiovascular risk. Because even though the LDL levels are actually not affected, they still have an increase in HDL levels and a reduction in triglycerides. And because the HDL is the thing that primarily drives cardiac risk, these patients still do way better despite the fact that their numbers don't look as impressive. So you're probably wondering, well, that's a very nice, interesting randomized controlled trial. That was just 600 patients. So, let's see whether it's borne out anywhere else. Are there any meta-analyses? Are there any other randomized controlled trials? There are quite a number of other papers, and it's interesting that they all show the same trends. This just happens to be, I thought this would be nice to mention. This is coming from my Indian colleagues. So I think you can see exactly the same trends here. And so certainly other authors from around the world experiencing the same results. So we've talked a lot about comorbidities, but there's lots of other factors that are going to make decisions for us as surgeons in terms of choosing a procedure. For those of you who may be earlier on in your learning curve, this is going to be important, and this is operative time. And of course, operative time reflects technical complexity, and it also reflects the number of operational goals or steps that you need to achieve during the procedure. If any of you are starting off and you want something useful in terms of those goals, I recommend that you go and read the paper from the Netherlands with Adelphi consensus on the operative steps. I think they've got something like 19 operative steps for a Roux-en-Y gastric bypass and 12 steps for a sleeve. But it's a really worthwhile paper for those of you who are just starting off with building your career. Anyway, so of course, as we've already discussed, the Roux-en-Y gastric bypass much more technically complicated. Sleeve gastrectomy certainly a simpler procedure and quicker procedure to perform. But interesting for me that the one anastomosis gastric bypass is essentially having the same operative time as a sleeve gastrectomy. The reason for that is because it's a short, or it's a small pouch, and it's easier to create than actually to perform the whole sleeve. And then there's just a single anastomosis to perform after your measuring is done. So these are some of the other major results in terms of if we're thinking more about complications. And I just wanted to highlight the things that are important. So once again, those are in red, and you can see leaks are really a bit more of a headache when it comes to sleeve gastrectomy. The nutritional complications are certainly there, and they are definitely increased in patients with one anastomosis. This is exactly what we would expect. Importantly, things like anemia and hypoalbuminemia. Dumping is a really big problem, much bigger problem after single anastomosis surgery than it is after Roux-en-Y gastric bypass. And some authors would argue that this is actually a benefit because it's part of the therapy. I think that's true so long as it's not profoundly pathological. I found this paper also a little bit interesting from the point of view that the mortality in sleeve gastrectomy was the highest. This is not borne out in all studies, so I don't want you to get a skewed view. But it does go to show that if you have leaks or if you have sepsis or perioperative sepsis of any kind, it drives mortality, and that's always a concern. And then, of course, weight regain and insignificant or inadequate weight loss are much more of a problem with sleeves. This is a little bit more detail on nutrition. And I mean, this is no surprise to you. I think we all know that malabsorptive procedures have got a significantly higher risk of malnutrition or of vitamin and mineral deficiencies. But most authors will agree that if you periodically assess your patients with laboratory investigations and you perform routine supplementation, particularly if your patients are compliant, you will have very few problems with any of these three procedures. Again, the highlighted ones that could potentially be problematic, especially with the single anastomosis surgery, will be your vitamin D and folate and iron. And this really is unsurprising when you consider the configuration of the anatomy in the post-operative situation. One of the big talking points, I'm sure you're all aware of this, is about customizing bowel length and making sure that one actually considers measuring common channels from the cecum, or making a decision depending on the patient's comorbidities. And there's definitely a lot of new information in this domain, which is quite compelling, and many surgeons are moving to customizing the decision making for each patient, not only the choice of the operation, but the choice of the bowel length or the choice of the common channel. And if you do this, some papers will demonstrate that the reoperative risk for nutritional complications can be kept as low as 0.1%. So we really have to try and figure out how to make this decision now. How are we going to decide between these three procedures? We have some long-term information. Some authors will say that 5 years is inadequate follow-up. I think we would love to have 30-year follow-up like we have for breast cancer patients, especially when it comes to debating the issues perhaps around mini gastric bypass and the problems with bile reflux and the potential risk for metaplasia and possibly for malignant transformation in later life. And we don't have any data that is compelling yet, but it is definitely a theoretical risk. So we have a number of things to consider, and this is nothing unique to metabolic surgery or in terms of our decision making, but we really need to consider a number of factors, mainly from the patient side, but also from the surgeon side, when we're going to decide which direction to choose. So there are some papers for those of you who are interested in taking a look at this. You can have a look. There are some papers discussing choices, decision making, patient selection, and all of them are interesting and compelling. But the bottom line is that I think, like with anything, there isn't a possibility for one surgeon to dictate or to determine what you should do in your own practice, because there are a number of factors. But there probably are some broad principles that you can adhere to. So these are the kinds of things that I think about in terms of choices. So I think gastric bypass procedure is suitable for patients who have a BMI of greater than 50, although I would be very reluctant to perform such a procedure with a patient whose BMI is over 60. Obviously, it's suitable for all adults, all genders, for elderly patients, but importantly also for younger patients. It's suitable for revisional surgery, it's suitable for diabetic patients, and it's definitely suitable for patients with gastroesophageal reflux and even with Barrett's. When I don't like Roux-en-Y gastric bypass is for patients who've had multiple previous laparotomies, or they've had complex previous surgery or pelvic radiotherapy, patients who've got complicated incisional hernias. These patients are really difficult to safely perform and predict the surgery, and what is already an extended operating time becomes much longer. In terms of sleeve gastrectomy, this is actually contrary to world trends, not my favorite operation, but it is a really robust procedure, and one can certainly argue that it's an acceptable first-line operation for a lot of patients. You can use it for all adults, again for all genders, and for elderly patients. It is also suitable for some revisional surgery, depending on the previous surgery that's been offered. And importantly, most people agree that it is suitable for younger patients. When I don't use sleeve gastrectomy is for patients with reflux or patients with Barrett's esophagus, and I definitely don't use it for patients who are super obese. Definitely the higher their BMI, I would be more and more reluctant to use this choice. And I think it's also worth noting that it's really not a successful procedure in terms of dyslipidemia resolution. So that's also something you would probably want to strike it off for. And then if you take a look at mini gastric bypass, this is a good operation for patients who are super obese, especially those who trending to the upper limits of what you would consider for a one-stage procedure. Again, it can be used for all adults and all genders and is safe in elderly. It's also a good operation for diabetics. There isn't a consensus about younger patients. Certainly there's no consensus around adolescent patients. I have my concerns, especially given the bile reflux and potential metaplasia debate. But if you want to know what other surgeons around the world think, you can take a look at there's also a really interesting Delphi consensus, there is no agreement, there's no consensus, and so there are many surgeons who advocate this procedure for young patients. I wouldn't do it, but you would be in good company if you chose to. It's not a good operation for cirrhotics. It's not a good operation for patients with Barrett's. And I would also say for those of us practicing in low middle income countries where we don't have the great ability for follow-up, if you're worried about your patient's compliance with regards to supplementation, I would be very anxious to consider offering a procedure like this to a patient who has not got great support, not got great infrastructure, and not got great insight into the nutritional dynamics. So I have tried to give you some of the information about the results and what that means to me in terms of decision making with regards to operative choices for my patients. And in conclusion, I suppose I have to say something safe, which is that every operation has merit. But I think if you have limited options, it gives you really limited solutions. And I would encourage every surgeon who's embarking on a metabolic practice. Of course, you need to begin to train with one procedure, but you need to rapidly build your repertoire so that you can offer multiple options to your patients. I have a good friend, also a surgeon, who likes to say that if the only tool that you have is a hammer, then every problem looks like a nail. And I would encourage us not to put ourselves into that position. So that's the summary of the information out there. I'm not sure if you want to take questions at the end, or I'm happy to do that now.
Yeah, Dr. Heather, I think that was a wonderful presentation and a very nice review of literature, as well as, you highlighted pretty well the advantages and the pitfalls of all the three procedures. So maybe because the next topic is kind of separate, we can have some questions right now, and then we'll have possible panel discussion in the end. So just to kickstart the discussion, how many, you said you are not doing OAGBs in your practice. So do you see other surgeons in South Africa? How many surgeons? Do you see a considerable number of surgeons doing OAGB? And what do you think? You must be getting those patients. What do you think the result, and why have you not started in your own practice if your colleagues are doing it around the country?
Yeah, thanks. We have a very interesting, I don't know what it's like where you guys are, but we have really interesting situation in South Africa. So it seems that we have surgeons who sort of fit into one of these groups. They're like believers in a certain procedure, and that will be their primary choice. And they will show you a case mix summary similar to mine, which is going to be their bias and then a scattering of other things. But I do have colleagues that are performing mini gastric bypass and who are vehement proponents of it. They have really good results for the most part in terms of comorbidity resolution. But I don't know if I'm speaking out of turn, but I'm concerned that the complication rates that I see are higher than what's reported in the international literature, which might just be a reflection on learning curve. But I have to tell you that in our own national databases, our results are not as good as the international literature. So that's the first thing is, despite the evidence, I'm a little bit skeptical. But the second thing is, despite my like strong recommendation, I do think that you must build your practice safely. And I think you have to pick something to start with and then do that, but do it only on the right patients. And then you need to build in, and I did not feel comfortable to bring a third procedure into our practice just yet. I'm not sure for those of the colleagues that were listening, I practice in a public sector environment, so I'm a state doctor. There are only 3 programs in the country for indigent patients. And we obviously have to be really careful that we have extremely good results. And so what we've done is to be really careful about case selection and about the procedures, because we've needed to build it in the public sector.
Yeah, I think that pretty much sums it up. And we actually need to be very careful about the results, whether you're in public or private, because bariatric is typically taken as a lifestyle procedure by a lot of patients, and one bad case can bring a lot of bad name to the fraternity. While I think the situation is pretty much similar here in India too, wherein there are proponents of MGBs who will always do MGBs, there are proponents of sleeves who will also always do sleeves. But yes, Dr. Narvaria is here, and Dr. Narvaria has been doing RYGBs for the longest time in India, but now he has switched his practice to a lot of MGBs. So, what are your comments?
Yeah, in fact, I had started with sleeve gastrectomy, then to Roux-en-Y and sleeve both, and last almost 6 years, I'm converting almost everybody into 1.5 gastric bypass. In fact, even my revision, my concept remains the same. Even if I do Roux-en-Y gastric bypass, I try to convert into OAGB kind of configuration. So I designed a new processor which will mimic like OAGB, but it is not actually OAGB, because once we have done Roux-en-Y gastric bypass, we can't do OAGB the way we want. So, but most of these patients, the reason of selecting OAGB is because the long-term outcome in terms of the weight regain. See, that's a major problem in our country. If you do sleeve gastrectomy and 30% people will come back to you with weight regain, they will say the surgery is failed. And those who are moving around in the society, they feel that this surgery is only temporary process, so why to go for it? So this is a major thing which I had seen in my practice, where people are coming back with weight regain, and it is very difficult to offer them and tell them, now you need a second surgery. After every 10 years, if you need a second surgery, or after every 5 years, nobody is going to accept it. So last 6 years, I started doing OAGB, and now almost close to 98%, I do OAGB as a procedure of choice. I do sleeve only to pediatric age group of patient. The lowest age which I have done is 3 years, and my oldest patient is 83 years. So a very select group of patient I still do sleeve, and that too when patient insists, the younger person who insists for sleeve gastrectomy, I still perform, but personally I don't like it. So this is mainly because, and that too after doing more than 2,000 sleeve gastrectomy, if I change myself, that means it has taught me a lot in last almost more than 15 years of my practice.
I think so. These are all very valid points, and all of us learn as we go along. Dr. Varia, being a devil's advocate, you are a very competent and a very adventurous surgeon. So I would use both the terms. What do you think about the unpredictable weight loss, which a lot of us see with mini gastric bypass? Some people go into malnutrition, while others do not lose enough weight. And the limb length of mini gastric bypass being different, and it's kind of earlier everybody used to recommend 200, now everybody is saying 150. So as even the Roux-en-Y surgeons like us, we have changed our limb lengths based on the MGB experience, and we are trying to make a longer BP and a shorter Roux limb. So what do you think? A diverted MGB, which you are talking about, or in your opinion, is MGB better, or a Roux-en-Y with changed limb lengths or changed pouch size? What do you think is better?
See, what Heather has brought a new word here was a customized surgery, or like modifying the surgery according to the need of the patient. So what I do in my practice is I customize the surgery according to the need. Like somebody who is not having a high BMI, somebody who's 32 to say 40 BMI, you don't need actually a tight pouch. So we can have a the pouch size of the OAGB different for the different people. And the limb length, I always consider 150 centimeter for everybody. Very rarely, I may go to 160 for those who are having super obesity, say more than 60 BMI. But otherwise, I do 150, and I make the size of pouch according to the BMI. So that is a new customization which I do. And those who are elderly people, the major problem with MGB is in elderly people of more than say 65 years of age, wherein they can have protein energy malnutrition, they have muscle loss. So to avoid it, what I do is I do a long pouch, like mini gastric bypass pouch of the stomach, and do the Roux-en-Y anastomosis. There, the BP limb takes about 125 centimeter and Roux limb about 100 centimeter. So this is called diverted OEGB, or we can call it long pouch Roux-en-Y gastric bypass. So the results of both these processes are published, and they are pretty good. So in older people, some weight loss is important. Even 30 to 40% weight loss is more than enough. We don't want to have, say, more than 50 to 60% of extra weight, because the quality of life is most important there, and there we don't want to bring them to near normal. So I always tell these patients, what is your expectation from us when we are doing this surgery, and accordingly we tailor-made the procedure depending on the need.
I think very well put forward, but I think this is also going to be one of the problems in comparing the procedures, that a lot of surgeons are now changing the procedure as they think is going to be good for their patients. So at 5 years down the lane or 10 years down the lane, or even whatever we are saying right now about the long-term outcomes of MGB, it may not be comparable to the procedure being done right now, because the limb lengths have changed, the pouch size has changed, the MGB has shifted to OAGB, and similar is changing with RYGB and sleeves also. Dr. Haider, you actually talked about the prediction of weight loss and outcomes after various procedures, and that's pretty interesting. All of us are wanting to develop a system wherein there is a way to predict which patient will do better with which procedure. And there are two calculators which I know online. One is from the Michigan Bariatric Surgery Collaborative, wherein they have pulled in the data from a lot of patients across Michigan state, and they provide results of a particular patient with a procedure. And second is by Cleveland Clinic. I think they have been pretty useful. What do you think? Do you think some kind of predicting score is useful? Do you use something in your practice? What do you say?
Yes, absolutely. I think these things, I like them for two reasons. First of all, I think they do assist with surgeon decision making, but I like them primarily because I actually use them to consent my patients. And I use them sort of as a tool to explain about, well, to manage expectations, but also to discuss complications. And so I personally advocate, I mean, I don't know if there's any superiority of one over the other. I think you must just choose one that's comfortable. I'm usually consulting with my patient with my phone, and showing them and running through the options, just to discuss choices with them. So I primarily use them for consent, but I accept that it's a good decision-making tool for the surgeon.
And there's a question from YouTube. Do you see the role of obesity after sleeve gastrectomy procedures going for knee replacements too? I think yes, all of us agree to that. So taking some questions in the chat box. The other question to you, Dr. Haider, is there an insurance cover for these metabolic surgeries in your country?
Yeah, thanks for the question. We have very limited insurance, so you have to be on quite high-end medical insurance. Most patients are not covered, and there are some optional clauses, and you have to make disclosures. So it's quite complicated, and it's still very expensive, the additional out of insurance pay. But because I work in the public sector, our patients are all uninsured, and it's really, it's one of the I think the most constructive things I've ever done in the public sector is to begin to offer metabolic surgery to our patients. We have such high incidence of comorbidities, and it's become actually the #1 cause of death for my patient population. So my patients don't require any funding, but it was a hard battle to convince the funders to support my program.
Right. So I think we'll take the other questions later on, while I will now request Dr. Mahendra Narwaria to enlighten us. Dr. Mahendra Narwaria is the chairman of Asian Bariatrics in Ahmedabad, India, and he has been one of the leading lights in the field of bariatric surgery in India, one of the pioneers. He is the past president and trustee of Obesity Surgery Society of India, has had a lot of publications and editorial board positions in various international journals. So Dr. Narvaria is going to speak on failed RYGB. Oh my God, now what? Dr. Narvaria, please.
Yeah, thanks Vivek for kind introduction. Thanks Heather for joining us, and thanks Meryl for inviting and making this possible to discuss this rare topic. And I'll take you through the problem which every surgeon is facing when they do Roux-en-Y gastric bypass. Or now we have many patients who are available in the society who underwent Roux-en-Y at different stages, now coming back to you with weight regain. So I think this is a very, very interesting topic. And though revision is my favorite subject, I prefer to talk about revision. That is why I opted to speak about failed Roux-en-Y gastric bypass, because we have very less to offer them when Roux-en-Y gastric bypass. As Heather has said, it is close to gold standard procedure, but I don't believe that it is. Still, we have a single procedure which is gold standard available on earth. We are still learning and evolving ourselves to different procedures. So Roux-en-Y gastric bypass is considered the gold standard, but its long-term failure rate is close to 20%, particularly those who are having more than 50 BMI. So the most common indication for reoperation after Roux-en-Y gastric bypass is inadequate weight loss, and it is indeed the most common reason where the patient requests for revision surgery. How can we define a failure when we don't even define a success? So we don't have a single paper, what is success of bariatric surgery or bariatric procedure. There is not a clear definition on it. And is BMI below 30 is the long-term goal, which we are expecting? Is the extra weight loss is more than 50% of extra weight loss, or comedy resolution combined with weight loss is our goal? And how can we talk about the revision if we don't have a definition where and if they fail? Unfortunately, there is no position statement from IPSO or ASMBS on what constitutes a success of any bariatric operation. So if you look at Roux-en-Y gastric bypass, there is a good outcome when there is no postoperative complication, adequate weight loss, resolution of complications like diabetes and hypertension. There is happy patient, and obviously when a happy patient see the surgeon always remain happy. Then we have a hot complication Roux-en-Y gastric bypass like bleeding, leak, strictures, and hernias, which can lead, which may need surgery. And there are cold complications like inadequate weight loss, weight regain after initial adequate weight loss, and cold complications like dumping, excessive weight loss, and steatorrhea, which may need revision surgery after Roux-en-Y gastric bypass. So a failed Roux-en-Y gastric bypass is considered when Roux-en-Y gastric bypass meet the patient's and surgeon's expectation. There is inadequate weight loss, failure to adequately control the comorbidities which were already present, and there is weight regain after initial weight loss and complications like dumping syndrome. So good preoperative counseling is very, very important. We need to explain the patient what is his expectation, what you can offer to a patient. So we need to understand and set a realistic goal for these patients, and more in terms of comorbidity resolution. Whenever a patient come, I always tell them, in case of any patient, I always prefer to talk about comorbidity resolution than the weight loss. The primary goal, whenever somebody is having diabetes or hypertension or hypercholesteremia, the primary goal should be resolution of comorbidity and then the weight loss. A surgeon's goal for surgery may be different from a patient expectation. We need to ask them, because somebody who remain obese for so many years don't want to look like near normal, because then they feel they're too thin, because even 24, 27 BMI for them is very low and they don't like it. So we need to ask them what is their expectation, how much weight loss they want to lose, and accordingly we design a procedure. Discuss in detail that and try to achieve a consensus before surgery, so that what is to be offered to them as a reasonable outcome after bariatric surgery. Identify at-risk patients likely not to follow the diet and exercise adequately, the poor follow-up patients with conditions which put them at risk of inadequate outcome like people who are having limited physical activity, patients on steroids and on anti-epileptic medication, or patients who are on psychotropic medications, they need to be seen cautiously, and the procedure has to be designed as per their need. And patients with unreasonable demands, like somebody who want to lose, say, those who want to reach, say, 15 BMR or close to that, should not be even offered, because you cannot achieve such kind of BMI from them. So preoperative behavior is very, very important, which can be done by psychiatrists or psychologists to understand the risk of behavior which they are going to have in the post-operative period, and endocrinologist evaluation is equally important. So why does Roux-en-Y bypass fail? There are multiple reasons. The one, the most common, is anatomical reason. That is mainly because of enlargement of gastric pouch or dilatation of the stoma. And in one study of Hengen, they found that more than 70% of patients with weight residuum has abnormal anatomy. So in anatomic consideration, we can think about gastrogastric fistula, try to evaluate and find out. This was first identified in 1995 as abnormal connection between the pouch and the extruded stomach. And it was earlier more commonly seen with non-partition staple line. However, currently the incidence is less than 1%. And GG fistula allows food to pass through the extruded bypass stomach. Hence, there is no feeling of satiety, and that can cause weight regain. There are no two Roux-en-Y gastric bypass are same, because we can't replicate the same procedure in every patient. There are different patients with different physiologies. There are difference in technique, pouch size, stoma size, and limb lengths. There are different eating patterns of different patients, and there is adherence to patient to diet and exercise by every patient is different. So we cannot have two identical procedures with the same outcome. So how do we approach to a failed surgery? We try to identify the obvious symptom, that is weight issue, identify the less obvious reasons behind the scene, like problem with the diet, high calorie meal and constant grazing, exercise and lifestyle modifications, emotional factors like underlying stress, depression or emotional eating, and physical limitations for those people who are bedridden or immobile. They need a different procedure. And how we can approach them when Roux-en-Y fail. So we need to have eating behavior evaluation, which can be modified according to their need, and it can be changed. Anatomic evaluation by endoscopy to evaluate the stoma size as well as the pouch size. We can have contrast study wherein we can have reconstruction of the pouch size and anastomotic limb. And the pouch size of more than 120 ml is considered as adaptable to revision surgery. Currently, the most common indication after Roux-en-Y gastric bypass for elective bariatric surgery, some patients are deemed to fail or become less responsive after a certain time. 1 in 5 patients, almost 20% of patients of Roux-en-Y gastric bypass may have a weight regain despite of good initial weight loss. Never be in too hurry to offer a second surgery in Roux-en-Y gastric bypass. Patient with initial adequate weight loss of say 60 to 70% of extra body weight will get the maximum advantage after revision gastric bypass. Patient did not show adequate initial weight loss or compliance after primary surgery will have less likely to respond to adequately to the second attempt of revision surgery. Thus, different method of surgery is offered to them. Like we cannot offer the same Roux-en-Y modification, but maybe we have to convert them into BPD, DS or similar kind of procedure like SADI and all. So there are conservative methods when we have overweight or some weight regain, and ideally it should be offered when somebody approaches us, when they start gaining the weight, and we try to catch them there, wherein we can check their diet. We can have modification there. Those who are having high carb, we can modify them to high protein diet, and we can control it. We counsel these patients for maladaptive eating habits like eating small frequent meals and all, and trying to address the emotional issues which they have. We use GLP-1 analog like dulaglutide, that is which can cause about 5 to 10% of extra body weight. And metformin I commonly use in most of my patients whenever they come back to me, even slightest weight regain, and they can have at least weight maintenance. And those who are having sugar craving or reactive hypoglycemia, they respond best to the metformin as well as acarbose. So what options we have to these patients? One is endoscopic, wherein we can have pouch cultivation by transoral endoscopic plication. We can have Rose procedure, or even the new stitch device, which is being used for endoscopic sleeve gastroplasty, can be used to reduce the gastric pouch by plicating it and reducing the stoma. Similarly, we have in surgery, we can have a trim of the pouch, or we can have, when on the trimmed pouch, we can revise the gastrointestinal anastomosis if the stoma size is big, or we can have a distalization of jejunal by which we can reduce the common channel, and we can convert it into BPDS kind of procedure, or in my own modification, it is considered to be a loop OAGB, where I'll explain in the detail how I do it. Maybe I'll be able to show the procedure also at some time. So in endoscopic process, we have different options. We have sclerotherapy, which can lead to fibrosis and thus limiting the stoma size. Then we have organ plasma coagulation to reduce the stoma, and we can have a Rose procedure, though the results are not so good. So nowadays people don't do it, but the new device that is endoscopic overstitch, I think being tried, and people are trying to reduce the stomach pouch by overstitch. So this is organ plasma, which can be done like this, which can have fibrosis and reduction in the stoma size. And this is endoscopic plication by Rose procedure. And these are different publications on these procedures, wherein they had shown some weight loss after this procedure. In surgical options, we have procedure like we can trim the pouch when the pouch is dilated, or we can put a band on it. We can have both bending the pouch after the trimming it, or we can move the jejunal anastomosis distally, by which we can reduce the common channel, and we can revise to another procedure like BPDS or modified OAGB, which I'm talking about. So this is a distance gastric bypass, wherein we disconnect the root limb and reconnect it closer to ileocecal valve, usually about 50 to 150 centimeters proximal to ileocecal valve. But there are studies wherein they have shown if we go closer to 50 centimeters, there are high risk of malabsorption, and they can have more complication. So most of people don't go less than 150 centimeters of the common channel. We measure the entire small bowel and decide the common channel length, and very short common channel leads to more malabsorption in steatorrhea, and there is resultant weight loss. Not only the fat loss, but they also lose their muscle mass, which is not good. So conversion from any other malabsorption surgery like converting them to BPDS or OAGB is still valid option, particularly in patients who are not losing enough weight after primary Roux-en-Y gastric bypass. Here again, the risk of malabsorption and muscle loss, skeletal muscle loss, is high in these patients. Placement of ring or adjustable band. There are publications, even I have done few procedures wherein we can place a adjustable band on the pouch, or after trimming, we can put a ring on the pouch and placate it. So this is like dilated pouch, which is seen here. And so this, in a study of 29 patients with weight regain after 5 years of post-Roux-en-Y gastric bypass, there are different approaches of revision technique applied, such as increase of the alimentary limb, application of silicone ring, or gastric plication. Overall, offering the silicone ring in 19% out of 29 was associated with higher extra weight loss, that is average about 20.62% after 9 months. This is another study wherein they offered a gastric band as a revision option in 8% post Roux-en-Y gastric bypass failure. And prior to revision, the mean BMI was 44 plus minus 4.5. After revision, the mean extra weight loss was 38.1 plus minus 10% and at 12 months it is 44.3 plus minus 36% at 24 months. Similarly, another study wherein they reported positive finding after using gastric band as a revision technique in 11% post-failed Roux-en-Y gastric bypass. The mean BMI decreased was 6.3 kg per meter square and approximately 20.8 to 16.9% extra weight loss at 12 months, which was observed. So this is another article which is talking about revisional laparoscopic pouch resizing for the inadequate weight loss, and here even the extra weight loss which was achieved was close to 29.1%. And this is publication on adjustable gastric band as a revisional bariatric procedure after failed gastric bypass, and here also the weight loss at 6 months, 12 months, 36, 48, and 60 months is significantly good. Like if you look at the 5-year follow-up, it is 47% of extra weight loss. So can we convert this person into BPDS? The very limited indications. One is indicated weight loss, weight recidivism, and those who are sweet eaters can be offered, but only risk is protein malabsorption but it is less frequent than the distal Roux-en-Y gastric bypass, because here the pouch size is bigger, so they can eat large size of meal and they can lose weight. So protein malabsorption is less than the distal Roux-en-Y gastric bypass. This is another poster popularized by my friend Dan Kotam, who was one of my partner earlier in a few of my studies, and he's from Salt Lake City, wherein he has done 32%. 9 of them was Roux-en-Y duodenal switch, and there were 23 patients who underwent SADS procedure, wherein in his procedure, what they do is they disconnect the pouch proximal to the anastomosis, and this the portion of the stomach. Then they disconnect about 1.5 distal to the pylorus, and they divide the root limb and then make loop anastomosis like this. So, and they keep about 300 centimeter of the common channel. So these are the steps of single anastomosis duodenal switch. That is what they call it. And if you look at the results, the operative time was 155 minutes. Early complication rate was 25%. Nutritional outcome was close to very normal. Weight loss outcome was 56.4%. Extra weight loss at 12 months, and BMI at 12 months was 29.9 kg per meter square. So this is significantly good. I'm waiting for his long-term outcome and with a large number of patients. So there are a few other studies which were published which has reported significant weight loss. The excess weight loss was 69% at 30 months and 46% revised to BPDS. Almost half of these patients were revised to previous Roux-en-Y gastric bypass because of duodenal switch complications. This is another publication wherein duodenal switch is considered as a safe procedure, wherein the previous failed gastric bypass process and so on. So this is converted gastric bypass to bilirubin diversion with duodenal switch with 9 patients, and here also the mean BMI was 35.8 with the extra weight loss of 64.1%. The BMI of course decreased by 9.8 and extra weight loss increased from 31%. This is another review article on revision after Roux-en-Y gastric bypass, wherein they have studied almost 24 studies with total of 866 patients, and out of these 24 studies, 5 were conversion to distal Roux-en-Y gastric bypass, 5 were revision of gastric pouch, revision of the gastric pouch and the anastomosis, 6 were the revision with the gastric band, and 2 were revision of bilirubin diversion to duodenal switch, and 6 were revision to endoluminal process, that is stomach fix, the percent excess body mass index after revision up to 1 to 3 years follow-up after BPDS was 63.7% and 76%. Distal duodenal gastric bypass, it was 54 and 52.2%, and gastric banding revision, it was 47.6% to and 47.3%. Gastric pouch anastomosis revision 43.3% and 14%, and endoluminous procedure it was 32.1% respectively. The gastric pouch and revision of anastomosis resulted in lower major complication rate, that is close to 3.5%, and distal duodenal gastric bypass has the highest, that 11.9% compared to other revision procedures. The mortality rate was 0.6%, which occurred only in distal duodenal gastric bypass group. This is another publication wherein laparoscopic failed gastric bypass duodenal switch, the preliminary outcomes, and here also the BMI they could reach was from 41 to 31, that is close to 10%, and excess weight loss was about 63% at 11 months postoperatively. So when do we need to convert to distal duodenal gastric bypass? Again, the indication was inadequate weight loss, weight residuum, and polyphagia. So this is what mean the distal gastric bypass, wherein the root limb is disconnected and which can be joined here. So distal root limb and reconnecting it closer to the ileocecal wall, usually 50 to 150 cm proximal ileocecal wall. So FOBI has reported an average of 20 kg weight loss and mean BMI decrease of 7 kg per meter square in 65% converted to distal duodenal gastric bypass. Nevertheless, almost 23% of these patients develop protein malnutrition, and almost half of them require revision surgery for this complication. So he don't advocate it. Now, Sugarman has similar experience, and he also reported high incidence of morbidity and mortality associated with these patients when they converted, because there the common channel was less than 50 centimeter. Mueller has found no difference of weight loss or residual comorbidities was produced when comparing standard duodenal gastric bypass, that is 150 centimeter root limb, with distal duodenal gastric bypass, that is 150 centimeter from the ileocecal wall. So what does this mean? We can now know that 3-month post-op follow-up is very, very important, and we can know from 3-month follow-up this person is going to achieve more than 55% extra weight loss. This gives us more power to diagnose and have conversation about patient, about what is next in terms of greater medical intervention and sleeve revision. Success and failure in person specific it is simply a result of patient's DNA and the nature of the surgery. It also suggests follow-up beyond 3 months may not be near as important for maintaining weight loss and goal of this patient. We need to have discussion with patient about inadequate weight loss even in the early follow-up. So those patients who are coming to us after 3 months or 6 month follow-up, we usually catch them there, and we try to add some medicine like metformin or kind of medications at the same time along with the procedure, so we can have good weight loss. And those who don't follow, we always tell them to think about revision surgery later. So if we talk about benefits of single anastomotic gastric bypass, I think everybody knows about it. It is a easily reproducible operation. There is no root limb effect, and there is better type 2 diabetes and cholesterol resolution after compared to duodenal gastric bypass, and it has similar nutrition problems like duodenal gastric bypass, and it is less than BPDS. Dumping can be there in these patients also. It can be early or late dumping. Early dumping is usually because of the osmotic load in a small bowel due to loss of pylorus, and late dumping is mainly because of carbohydrate overload. The dumping, if you talk about treatment, which can have diet modification like small frequent meals, decrease the carbohydrate diet, add the acetazolamide, metformin, or acarbose. We can use long-acting octreotide, and in few patients we need to even reverse them. I reversed at least 2 patients because of severe dumping back to normal. Excessive weight loss is another issue which can be catered by lengthening the common channel. Most of people, they recommend more than 300 centimeter common channel, reversal or back to near normal for those who are having severe malabsorption, and we can convert to any other posture if needed. So the answer in my practice is that one gastric bypass, that is OAGB, and this is said that a wise man's question contains half the answer. So this is what I convert almost everybody in my practice. So this is algorithm wherein they have talked about revision after failed duodenal gastric bypass, which is published. So when BMI is more than 35 and there's nutrition deficiencies, you can consider that patient to be converted into LSG. There is weight residuum. There is volume of pouch is more, we can put a gastric band, or we can reduce the pouch and revise the anastomosis. Those who are having sweet eaters with no pouch dilatation, we can convert them into BPDS or distal duodenal gastric bypass. And those who are having failed after weight loss after duodenal gastric bypass, we can offer them again BPDS kind of posture or distal duodenal gastric bypass. I'll just take you through a few videos. So this is a failed duodenal gastric bypass wherein we'll reduce the pouch size and put a band. You can see the pouch, which is quite big here, which need to be trimmed on a bougie. So we put a bougie there. This is quite old video, maybe more than 5 years now. Usually we are able to do it with the 2 cartridges, and then we create a tunnel here and put a band. This is, can you see this?
Yes, we can see this.
Yeah.
Yeah, we see it. It's great.
This is another revision. So here we disconnect the pouch, the anastomosis, then retrim it. So you create a new stoma there. So excising a small part of the anastomosis and then doing this anastomosis again. I usually take out the fat around it so that you know the stomach serosa well, and you can take sutures on it, and always do 2-layer anastomosis. This is putting a band on it before the anastomosis. So just create a small tunnel so the band will remain there and it will not migrate. So don't try to take out this tissue, and sometimes you can find a left gastric pedicle here. So this is a phobia band which we have used earlier, which I don't use it almost now since 5 years. This was very cumbersome to lock it. Then take the rule limb there.
Right.
So this is a posterior layer which is taken using endo stitch. And do the anastomosis about 2 centimeters. You can see the bougie through this opening. Yeah. So and create the same size of the opening on the jejunal side. So here we can do it even without the stapler. Also, you can do only sutured anastomosis using the Vicryl, or you can use the stapler and then close the enterotomy. We try to see the bougie here because sometimes you can do an incomplete opening because of the stomach thickness is so much in a revision patient, the pouch size. So it's better to see the bougie through it and then you fire the stapler. So you can see that we hardly fired, say, less than 2 centimeters, almost 1.5 centimeters, and then we created the anastomosis. over the bougie. So it should not be less than a bougie size. Otherwise, they can have nausea, vomiting in the postoperative period, and it should not be too loose as well, because and you can take one more layer on it to complete the anastomosis. And then we do the leak test, and then changing the ruling, disconnecting it and making it a distal gastric bypass. But usually I don't go beyond 200 centimeter, even if I'm revising it. So disconnecting the jejunal anastomosis, then taking, counting again beyond it. So adding some more 100 centimeter beyond it. So we are increasing the BP limb now. So the previous BP limb was 50 to 70 centimeter. Usually in my early practice, I used to do 50 to 70 centimeter. Nowadays, we do more than 100 centimeter. And then you create a new anastomosis here.
I think the video has paused.
Did we lose both Dr. Nawaria and the video?
Yeah, I think there was a connection problem there. All right, so I think pretty interesting videos shown by Dr. Nawaria, and it is definitely a very difficult topic to deal with. Only experienced surgeons should venture into revising these kind of operations, because the outcomes all of us know are not good. So whatever you may do, a failed Roux-en-Y gastric bypass patient is not going to have a good outcome. And if anything is done to revise, or to kind of do whether endoscopy or laparoscopy or robotic, it's going to be a lot of effort and possible complications, but not very good outcomes. So I think we'll wait his joining back. And mini gastric. Yeah, Dr.
Maybe I can ask you what your opinion is, Dr. Vindal, because one of the nice things, even for surgeons starting off their metabolic surgery career, if you discuss redo surgery, revisional surgery, or failures, you learn a lot of important nuances with respect to technique. What are your key recommendations to young surgeons in terms of technical failures to avoid?
I think that's very important, and one of the most important things is, where do you get trained, and your mentor, what were the procedures that he was doing, and he or she, and what kind of technical pearls have you learned, because there's a lot to different procedures, and that is the biggest pitfall of comparing literature. If you compare, say, 100 Roux-en-Y gastric bypass with another 100, and you add up to 1 lakh cases, but those 100,000 cases are all different, because they have been performed by different surgeons with different technical sets. So I think if we like if we talk about sleeve gastrectomy, we can all of you that we typically now go 2 to 3 centimeters. We just make it 40 French wide. We take care to remove all the fundus. We just stay 1 to 2 centimeters away from GE junction to avoid disrupting the GE to prevent any reflux. And we always look for our pouch size. It should be, just optimum, and there should be no extra dilatation. When we go for a gastric bypass, we make a gastric size of 25 to 30 mm, and the BP limb length.
You're a little bit muted. Can you?
Oh.
Thanks.
Hear me?
That's much better. Thank you.
Rowan, the movements now we are doing is 100 centimeters BP and 100 rule in and 30 ml gastric pouch. So one is there. We lost you.
Yeah, now I'm okay. Can you... Hello?
Yes, now we can hear you.
Welcome back.
Yeah. So I'll just take you through the last. Host, please allow me to do it.
Okay, so
Deepak, yeah. So maybe I'll just take you through one more, my last revision, which I was talking about, converting into OAGB kind of procedure. So this is, yeah. So here I disconnect the root limb. Usually we measure it to check for the jejunal anastomosis. So I think the limb length was not so much. And do the dissection behind the root limb.
Dr. Nawaria, we just have a white screen.
Oh,
we don't have a video.
You don't have the video? Oh,
no.
Wait.
I think you can just stop share and then start sharing again.
Maybe yes. Or you can have new share. Wait. No.
I think in the interest of time, we can just discuss because we could see, is this?
I don't know why it's showing.
I think there will
be maybe last try. I think this should work. Can you see this now?
Yes.
Yeah. So yeah.
We cannot see the video. No.
Now
we just see
my screen sharing was paused. I don't know.
I think there will be lots of questions. This was a fantastic presentation, a lot of really useful information. We
can take questions. You can stop. Can you see the video now? Are you able to see? No?
No.
We just see.
I think let us take the questions if we are not able to share the video.
All right, I think that was a wonderful presentation by Dr. Varia, and he took us through a lot of fine points and published literature about revising a patient with Roux-en-Y. And when we lost connection, we were just talking about how all these patients who are going to need any revision after Roux-en-Y gastric bypass are not going to do as well as a primary patient. So whatever we may do, the result is not going to be as good. That we need to remember. And it's it's for an expert like Dr. Nazwaria, who has a lot of experience to, toil around with a lot of these options. So we should not just see his videos and start trying all this. So that was the first thing. Now, there are a few questions. So would you recommend MGB as a revision for failed sleeve or weight regain? I think I'll just answer that. Because MGB, I am not pretty sure about revision for sleeve. We don't use it because it has an unpredictable weight loss, especially as a revisional procedure. Sometimes you see some weight loss, sometimes you see actually no weight loss after you convert a sleeve to MGB. So typically we would do a SADI or a duodenal switch if the patient has failed sleeve, or either if the patient has failed sleeve with reflux, we would do a distal Roux-en-Y gastric bypass.
I think problem there is whenever we have sleeve gastrectomy or the long-term follow-up, we will find adapted bowel. You can see the thickness of the small bowel, which is very significant, as well as the bowel looks dilated. So the thickness and diameter will define which portion of a small intestine has adaptation. So if we go beyond it, or we do bypass after revising to MGB, we may need to re-sleeve it again and create a pouch and do the MGB. That is what my choice is. And then I do a distal anastomosis. Don't stick to 200 or 250 centimeter, but depending on the length of adapted bowel, which you can always count and observe and do the anastomosis distal to it. But yes, you're right that initial practice, we should not try to do it because results are very, very unpredictable. It happened within my initial practice when I did revision 250 centimeter and there was no weight loss.
All right, and there is one more question for you, Dr. Nazwaria. What do you see for the ischemia in resizing of pouch? Like how do you handle the issue of ischemia once you are resizing?
I don't see any reason of ischemia in a revised pouch. Whenever we resizing, there is no ischemia, because stomach pouch has a very good vascularity. So there is no such ischemia, and I always do 2-layer anastomosis. So I don't have a single leak in any revision.
All right, wonderful. So ischemia definitely is not a big problem if you are sticking to surgical principles. Yeah. Stomach is a well-vascularized organ. Dr. Heder, there is a question. If a super obese patient is above 60 years, would you advise metabolic surgery? Will it be safe?
I think it depends on the situation with respect to your resources. I mean, the main thing that you need to remember is the balance between the long-term morbidity and mortality gains that you're trying to effect with regards to the surgery. And obviously, the longer the longevity of the patient, the more beneficial it's going to be. So obviously, I strongly advise to offer the surgery as early as possible. In my practice, I have a sort of watershed area or watershed age group between the age of 60 and 65, depending on the patient's functional status. I don't offer any surgery to anyone over 65, but I would consider it if I thought that there was going to be significant benefit. But yeah, you need to be cautious, and you need to consider what outcome benefit you're aiming for.
Yeah, I think I prefer to do these patients even at 65, or my oldest patient 83 years, wherein we could ambulate him after the one who was bedridden, we could reduce 30, 40, almost close to 20, 30 kg weight, and patient become more mobile. There, the pouch size is not reduced so much. We don't want to reduce the capacity of meal in older people because their meal size is already reduced significantly at that age. So don't reduce so much the meal size, and don't do distal bypass. Don't try to do bypass even more than 150 centimeters, maybe even 125 centimeters with some modification. Even the increased GLP-1 itself is sufficient to have that much weight loss, and their quality of life improves and they do well. And partial resolution of the comedy is equally good. We don't have to achieve 100% resolution of their diabetes or anything, because these patients, you don't need to have so much comorbid resolution, but quality of life should be priority in these patients, wherein we can redesign the surgery according to their need.
Yeah, I think age is more, physiological age is more important than the chronological age. So sometimes we will find 55-year-old looking like 80, and sometimes you'll find 70-year-olds looking like 50. So we just need to take the functional aspect also into consideration when we are deciding on these things. There is one question about gut microbiota assessment in future, and its impact on which procedure may be appropriate for specific patients. I think a lot of research is going on. We are also assessing the gut microbiota in our patients of sleeves and gastric bypasses. But till now, there is no one who is close to predicting that this patient having this kind of microbiota will do better with this specific procedure. So it could come up in the future, but it's going to be a long way. Now, there's one more question. Do we have experience of having severe reflux post-1 gastric bypass, which did not get medically controlled? If yes, how was it managed? So this is by Dr. Shahnawaz. Dr. Narwaria, have you seen in your practice severe reflux post-1 bypass? And how
not so severe. Most of these are medically managed. We don't need to. I never revised anybody, and only maybe 1 or 2 percent where I could find a hiatus hernia along with it. So I did fundoplication on the bypass stomach, and that has resolved. So using the bypass stomach, you can create a fundoplication, and that will resolve the reflux.
Typically, you will see these kind of situations when the pouch has migrated up, and because of a large hiatus. So that correction is also quite important.
And or sometimes if you put a band, I think the proximal stomach, the G junction get dilated. Those who are volumeters, they can dilate it and they can have reflux.
Right. There is one question regarding the BMI criteria for endoscopic sleeve gastroplasty. So we have been doing endoscopic sleeve gastroplasty for last 2 years now, but there is no set BMI criteria right now. And all classes of obesity can be a candidate for endoscopic sleeves. While I believe that there should be a BMI criteria which should be set after a consensus meeting or a consensus publication from experts is taken. But there is no published BMI criteria for endoscopic sleeve right now.
I think ideally it should be offered to those who are not qualified for surgery and still they want to lose weight, because here the weight loss requirement or the result is having very low weight loss, maybe 10 to 20 kg. So offering them to morbidly obese people or like super obese, does not make any sense. And I already published a randomized double-blind study almost more than 5 years back, where we compared the sleeve gastrectomy with gastric plication, and the results of gastric plication were not good. So I think looking at the experience of
efficacy, just tell him that gear.
Hello.
Yeah, please continue.
Yeah, so I think the gastric plication, which was almost 6-7 years back, that was the procedure to be talked about in most of conference. In fact, one of the IPSO Congress, I could see so many people are talking about gastric plication. Nowadays, nobody talks. That means the result is shown after gastric plication, though that is technically better procedure because we have controlled plication. We can do the sizing also, and we could not replicate a good weight loss with the gastric plication. So similarly, I think endoscopic sleeve gastroplasty will have similar outcome on the long term. So we just need to wait for a few more years and we'll be able to see. Already people have started publishing the revision of gastroplasty to different processes. So I think we should offer it to those who are not qualified for surgery and those who are scared of surgery. We can just offer, and those who are in good quality of good lifestyle which they are having and they are not getting benefit by diet and exercise, we can add this as a third tool to achieve it, and they can continue a good lifestyle after the procedure.
Dr. Narwaria, you mentioned that we should offer it to people who are scared of surgery, and that is 99% of eligible patients. So you will get
that is surgeons' expertise, how to convince.
So we actually added this to our toolkit because of the same reason, because a lot of patients are worried and scared, and we tell everyone that if you get a bariatric procedure done, it's more efficacious and it's cheaper. and it's more time tested. But even then, people are scared of surgery. We have to acknowledge that. And there is a question to you, Dr. Narwaria. Do you count total bowel length in all revision surgery? How much commonly you prefer in your practice in regards to distal bypass?
Yeah, I always count the total bowel length, and I don't go beyond. If you are doing distal bypass, the common channel should be more than 150 centimeter. I don't go beyond it. Preferably 300 centimeter. That is what my choice is.
All right. So this was Dr. Anand Patel from Gujarat only, and
Anand Patel is nowadays in China or Taiwan.
Don't say China. So
sorry.
So can I ask you something, Dr. Nawaria? Some surgeons would say that we have inappropriate expectations and that we should tell our patients that revisional surgery is absolutely one of the things to expect, just like a joint replacement. Or do you believe that there are technical modifications or other patient factors that we can modify significantly enough to be more predictable?
I think we can modify the procedure according to the patient's lifestyle and their eating habits, and we just decide accordingly. And yes, I always tell them that don't expect the same result which you achieved in the first surgery. And here again, we motivate them to have a good lifestyle after this surgery, because it's a last choice, this last option they are opting for. And if they don't modify their lifestyle, they will not have good result.
I think, and one of the important things which Dr. Narwaria also mentioned was prediction of weight loss early in the post-operative course and or maybe pre-operatively. So I recently wrote an editorial in Surgery for Obesity and Related Disease on the same topic, and what we found by reviewing the literature is if you put your patients in a pre-operative weight loss program and then you track them, people who do better with pre-operative weight loss do better post-operatively. And the second thing is, if you track their weight loss post-operatively, you can identify people who are going to lose less weight 1 month after surgery. So if you have identified a risk group at 1 month after surgery, you can work with them. And now with pharmacotherapy coming in a big way, you can add those pharmacotherapies to let them achieve 70 or 80% excess weight loss. Otherwise, if you don't do this, then those people will just end up losing 50% of excess weight.
I think, Vivek, artificial intelligence will be answer to this. I think in future we can put everything into our database, and artificial intelligence will tell us which person will behave in the post-operative period, how much weight loss we can achieve. That can be predicted by AI. So that people are working on it. Even people approach me from America that if you submit all of my videos and all the data, they will put in the system and they will try to analyze it, and maybe they can come out with a predictor of weight loss and resolution of comorbidities and by artificial intelligence. So that is new thing which is coming up.
Our 5,000 videos of gallbladders are already in that algorithm, and it's coming up. So they wanted, I think I was supposed to do some complication panel discussion also, but I think it's a lot of time. Can someone from Merrill come in and tell whether we need to end this, or should I, make 5 or 10 minute presentation?
Nico?
Yes, sir. Dr. Shraddha?
Shraddha?
Yes, Nico.
Yeah. So, yes.
Or, you want me to do that panel discussion?
Sorry, I didn't get you, sir.
If the time is over, I think we can end it, or otherwise I can do the panel discussion on complications as we discussed earlier. But I think we are already ahead of time, no?
We are ahead of time, sir, but you can take a call, no problem.
I think we can just maybe thank the speakers, and it was a wonderful session. We have taken almost all the questions. Thank all the audience. Mr. Krishnan Vishwanathan is here, who is the business head of Merrill in India, and I think he's going to say the vote of thanks. Dr. Vishwanathan.
Hi, good evening.
Hi, good evening.
And good afternoon to Dr. Heather. I think in South Africa it should be about 4ish. But yeah, maybe a good evening to you also. I think first up, it's so wonderful to see everyone hale and hardy in these troubled times. And I think thanks a lot, first up, for serving all so many patients in these troubled times, helping everybody. And after that, coming over here, maybe exchanging ideas. I still feel, Dr. Bindal, if you still have time, we can go ahead with some 15-20 minutes of panel discussion, because it was a very interesting conversation. I'm sure there are certain ideas within you, but yeah, there is also a time limit. So the clinicians have to decide. We are at home, so no problem.
Yeah, I think Vivek, you can take few slides and maybe you can take few more questions and probably.
Okay, I'll just show some videos and
Please, thank you.
If you, I can if you are kind of busy and just help me anytime, but I'll maybe just show some videos.
I think those who are busy, they can leave. So
I'll,
people are, see, more than 150 are waiting for this. So that means it is important and people want to see it.
Okay, so you can just see this video and I'll like the panelists to come in. This is the sleeve gastrectomy being performed. These are not my videos. These have been given to me by someone, and this is the second trial being done. So a sleeve being there, and now you can see something has happened here. So you can see what is this? This is the BG. So what has happened is the stapler has actually cut the BG, and
wow.
This is a big problem there. So now what to do? Now you can see the same case. How the clips are being removed and there's a big hole in the sleeve. So what would you do, Dr. Narvadia, here?
See, I personally feel if we can close it on bougie in 2 layers, I can do it if there is enough space. Otherwise, I convert it to Roux-en-Y gastric bypass.
Dr. Heather, what would you do in this kind of a case?
Heather is not there. Is he there?
All right. Okay. So here the first thing is the bougie integrity has to be checked. The surgeon has removed the bougie, and now he has sutured it. So he has gone ahead with the sleeve and then sutured it back with a running suture. This has its own pitfalls. There could be a stricture which you can make here, and a stricture here can lead to a delayed leak or a torsion leading to a lot of reflux later. But yes, this is the option. But I agree with Dr. Narvadia. Changing it into a Roux-en-Y configuration is a very good bailout. While you should have a consent for that as well. So we basically consent for both sleeves and Roux-en-Ys in all these kind of cases.
I always take consent for all the process.
Yeah.
Even if I'm doing sleeve, I always take that if needed, we can convert it into Roux-en-Y.
All right. So this is another case. I am just kind of showing these things after Dr. Narvadia has shown his excellent videos so that everyone just don't go back and start doing cases without safety. So you can see a sleeve has been done and the methylene blue leak test is being done. Everybody is happy in the theater. There is no problem, but somehow the sleeve is not dilating when the methylene blue is being injected. And, surgeon is worrying what is happening. But now you can see there is some balloon kind of thing here. And the upper part of sleeve is dilating. So what is happening here? You can see a big balloon.
He used a balloon?
Yes, so methylene blue has been actually filled into the balloon by the anesthetist. And the balloon ruptured the sleeve at the GE junction. So now this is a heartbreaking moment for the surgeon. You skip a heartbeat here. And this was an uneventful sleeve. So the surgeon now is thinking what to do. So you first need to define the upper boundary here.
Yeah, he has perforated the sleeve actually.
The sleeve has perforated and now you need to define the upper margin of the perforation because it has been done at the GE junction. So actually, this was one of our cases, and this was 8 years ago. And then we basically did an endoscopy to look for the upper end, and you can see that this is this is the upper end of the perforation, and then we sutured it. So starting from upper to lower, and we sutured it using one layer of continuous suture. This and then we did a check endoscopy at the end after everything was sutured, and a drain was kept. So this patient actually developed a perigastric collection after on post-op day 5, and which was, kind of on a CT scan, we could see that it was slightly away from the drain. So we just repositioned the drain bedside, and it was drained. And then the patient was discharged on post-op day 10 on liquid. She did well. But yes, this is a complication which can happen, and obviously you need to take care about all these precautions with bougies and anesthesia team putting in methylene blue and air. We have had cases in various hospitals where air has been pushed into the balloon and it has perforated the sleeve. So this is another case. This is a check endoscopy being done after a sleeve gastrectomy has been done. And I don't know how many of you have seen bubbles, but this is how the bubbles look like if you have a leak in a sleeve and you are doing an endoscopy. So with an endoscopy, you do a air leak test. And this is 83 BMI lady.
Wow.
So, and you can see this, this pinpoint perforation here. And you can see the bubbles coming out. So with the endoscope, we have localized this perforation, and we are just going to suture it. It is on the staple line only. So somewhere there has been a technical failure of stapling. It was over soon, and the patient did well without any kind of problems in the post-operative phase. While if it went undetected, it would have been almost a sure shot mortality at this BMI. So I think this is very important, and we actually find this endoscopy as one of the best tools to look for leak, bleed, intraluminal bleed, and also we always tend to see our sleeves and our bypasses and our stoma sizes through an endoscope, and it gives a better better idea about what you are doing intraluminally, because we are just seeing the extraluminal part, not the intraluminal part. So, okay, this was a band to sleeve. All right, again, let us go to maybe. All right, so this is, I think, yeah, this is a sleeve gastrectomy which is being done. And now you see there's something here. So what could it be?
Yeah, band.
This is a
buckle of the band.
No. This is a temperature probe. This is a temperature probe
you put in the stomach. Oh.
Pushed into the stomach by the anesthetist, and obviously the surgeon is not supposed to know about it. So the surgeon has divided it, and now it is seen in the staple line.
My God.
So this is again a
disaster.
a very difficult moment. So the temperature probe is being removed, and that's why we need to say all tubes out at the time of firing, and we need to be sure that bougie, temperature probe, or Riles tube are not there. We have had nasopharyngeal airway also pushed in by one of the anesthesia team colleagues while he was manipulating the bougie. So, and in all these cases, you need to be sure about the integrity of these tubes which are divided, because sometimes, you can have multiple level divisions of the same tube, and you may leave some part of the tube inside the specimen or on the patient side. So again, this is suture and the patient did well. This is over the scope clip. Let us maybe go to OAGB, volvulus and internal hernia. So OAGB, this is a case where the OAGB patient has presented with volvulus, and this video has been given by Dr. Raj Planiappan, I think, and this patient was almost 1 year down after surgery. She had a lot of abdominal pain, and CT revealed twirling of mesentery. So while whole of the bowel walking is being done, and you can see here, this is the mesenteric defect or the Peterson's defect. So actually Peterson's described the mesenteric defect or the Peterson's defect in a loop gastrojejunostomy only. This was in the year 1900, and he described in Billrod 2 anastomosis. But then after Roux-en-Y was described, it was, that paper was searched and the name of the defect was ascribed to that paper in a Roux-en-Y gastric bypass. So this is after, after the...
Yeah, it is difficult to understand. I don't know. I had not seen a single internal hernia so far.
Yeah, it is rare in OAGB.
Very rare.
So he has made another anastomosis there. He has undone the previous one and made another anastomosis.
So he kept MGB only?
Yes, he kept MGB only. He kept it to be MGB only. So I think now many people in OAGB also, they are closing that Peterson's defect. Are you doing it, Dr. Narvadia?
No, I don't do it. Yet to see a hernia.
Right. But I think it could be one of the learnings, because a lot of people didn't do the defect closure after RVGBs also, but of late they are doing it.
I think the alignment of the bowel is very, very important there when we are counting and taking it up. So my technique is different. So I think maybe in future I'll be able to.
Yeah, I think this is important. This is definitely important. These technical steps. How do you take it up? How do you future it?
So if the BP limb remains on the one side and which is hanging nicely, I don't think there is any such reason. So
yeah. All right. So stapler malfunction, lap removal of fluid. So I think let me just. So staplers can malfunction, and it can happen with any stapler. So this is a single incision sleeve gastrectomy. First fire being done. And you see the stapler is jammed. Now it is not opening up. So what to do? It's
everything in their rule book.
This is what I think they have
there are various options to, you know, reverse it in the gun. The surgeon is trying to open it by any ways and even break the stapler. But many times nothing works.
Yeah, in one case I had this problem. What I did is I put another port and stapled there proximal to it and on both sides. But that was Roux-en-Y gastric bypass. I could do it, but in sleeve gastrectomy you don't find such space. So
yes, without the incisura it will be kind of more difficult to.
Yeah, very difficult.
Most of the firing is done. So the problem is see how much we could do that. You could see that completely stapled almost to the end.
Now you can see how using the instruments, the stomach is being pulled out of the jaws of the stapler. And now the bougie is spouting out.
Yeah, it's already perforated.
So there is a question here again, similar kind of thing, whether to go ahead. And now the surgeon has completed the sleeve and then he has sutured that defect.
Okay.
So maybe there are a lot of more videos also on various kind of things, but
and that too it was a single port. So
I think in the interest of time, I'll just skip this, and maybe these are situations which we encounter. Stapler malfunction is a very common situation, not very common, but not uncommon also. Like we encounter it once in a while, and you should know your ways around it. It's very important to be able to do multiple procedures so that you can bail out with another procedure, or have different. And you should know your staplers very well. So that is where company people come into play. You should know all the nuances of that particular stapler, whatever you are using, and it really helps. Sometimes with a little nuance, you can open up and you can do something which otherwise you will not be able to do. So I think with this, we'll have any questions from the audience or anything, Dr. Bavaria,
No, I think it was very, very interesting videos which you brought. I think the beginners will learn a lot out of this. That's very good. I think the beginners should always have 2-3 guns in their OT available every time. So somebody who is beginner bring only one such stapler which has malfunction, they are in trouble. So, and always one should have a senior surgeon when they are doing surgery as a guide or mentor in the theater, so that any such problem at least can be handled together.
Over to Mr. Vishwanathan. Thank you.
Hi, thank you. Good to see you, Dr. Bindal. Good to see you, Dr. Narvaria. And once again, from the entire Merrill Endosurgery team, domestic, international, and all the people who have joined us beyond India also. I can see a lot of international guests also. This is possibly our endeavor to bring boundaries together, and I'm thankful in this way to COVID that even within our system, both the teams are able to collaborate and get both the domestic and the international KOLs together for a conversation. In fact, we are also learning in this process. Apart from working from home, you're also working for home. So I'm sure everybody has their own perils. So my wishes to everyone, just stay safe. And we will have more such engagements, we can promise you. And there are more excitements planned as we go along. Some more innovations that we are trying to bring to the table, possibly for the domestic market and maybe some point, later point in time for the international markets. So we'll stay in touch. Nothing else. Thanks a lot. Namaskar, and God bless everyone. Stay safe. Dr. Shraddha, anything from your side?
Thanks a lot, Krishnan, for the vote of thanks. Thank you so much, everyone, from all the teams present here. And we'll see you all again. Thank you. Have a great evening.
Thank you so much. Bye-bye.
Thank you. Bye, sir. Bye, Narvaya, sir. Bye, Vivek, sir.
Bye, Dr. Narvaya, sir. Thank you, Bindal, sir.
Thank you, sir.
Thank you, Nico, Chintan, Krishnan.
Thank you, sir.
Thank you.
Thank you, sir.